Good afternoon, everyone, and welcome to this webinar, which I think is going to be a fascinating hour. It's part of our Successful Change in the NHS series, focusing on positive deviance and what role positive deviance can play within that. My name is Richard Torn.
And I'm Danny Ryan.
And delighted to be joined by a literal international galactico of speakers today. We have Lars in Copenhagen. Good afternoon, Lars.
Good afternoon. Happy to join.
And we've got Rebecca and Ruth joining from Bradford. Good afternoon, Rebecca and Ruth.
Hello. Hello.
And we'll come back to you to do full introductions as we go through. Thank you very much indeed for joining us today. As I said, this is part of our Successful Change in the NHS series. It's a collaboration between Kaleidoscope, we're a social enterprise set up to bring people together to improve health and care, and AbbVie, the pharmaceutical firm with a particular focus on sustainable healthcare for the long term. It's one of a number of events we've been running in partnership. Danny, we've already done a lunchtime discussion.
Yeah, we had Disagree to Agree with Anna Winfield from Yorkshire as well, talking about patient safety huddles.
Other regions are available, but we do seem to be profiling a lot of work coming out of Yorkshire. Another event coming up this week?
Yeah, so on Friday, we've got a half-day event at still a small number of places available, so if your interest has been piqued by this webinar or the lunch, you can still join us on Friday.
Thank you very much indeed. So we're going to hear from Lars, Ruth and Rebecca all about what on earth is this thing, positive deviance. If this was a face-to-face gathering, I'm sure we'd be asking you now, raise your hand if you'd heard of this before. You're still welcome to do that. It's slightly less effective when we do that as a webinar. But we're going to be hearing from Lars, Ruth and Rebecca. But more than anything, this is very much designed as a discussion. Danny, how can people get involved?
There are three ways that you can get involved. The first is to email us at hello@kaleidoscope.healthcare, and I'll be picking up those emails as we go through. You can join us on Twitter with the handle at Kscope Health, and also finally you can use the Ask Question button, which will be just on the right-hand side of your screen, and we're picking those up too.
Thank you. We are recording today, so if your technology decides that it just can't cope with the heat any longer, don't worry. We will be getting around the video later on, which you can share with all of your friends and family and all those interested in our topic. It's just a reminder, so we're Kaleidoscope, working in collaboration with AbbVie. We thought positive deviance would be a fantastic item for today's discussion, partly because I think it's a tool which we'll hear more about, but it has real potential for application in the NHS, but in a nice contrast to so much of our discourse about healthcare, it focuses on positivity. It focuses on when things have gone right, what underpins them going right, which, Danny, I'm sure you'd agree, we possibly don't spend enough time thinking about.
And well, we do talk about what's gone well, but not enough. And how do we talk about it? How do we know what really is good and what's bad? Well, hopefully we're going to find that out today.
Lovely. So no pressure, Lars, Ruth, Rebecca, but you've probably got a lot of people who are going, this thing, I really don't understand it. What is it? I've already got enough jargon going on in my life. How can this additional bit help? So there we go. That's going to be our topic for the next 55 minutes. We really look forward to your questions as we go through. And Ruth, Rebecca, I think you're going to kick us off. Over to you.
Yeah, well, thanks so much for inviting us to this webinar. We came to this concept really for exactly the same reasons as you've just described. That well, I've been a patient safety researcher for more than 20 years now, and I was getting a bit fed up of the relentlessly negative focus on what goes wrong in healthcare and the identification of negative deviance. And I wondered if there was some approach that might allow us to turn that on its head and do something a bit different. And just as I was putting together a bid for some funding through the National Institute for Health Research Clark programme, which is Collaboration and Leadership for Applied Health Research and Care, I was introduced to this concept. Somebody told me that in international public health, work had been done to identify positive practice from the bottom up, to look at where communities were doing exceptionally well on a variety of different things, but obviously the classic example that Lars, I'm sure, will talk to later is the example of the shrimp use to feed young children in Vietnam. And I thought, this sounds like a delightful concept that we could use in healthcare. And so we started to explore what the mechanisms might be and what the processes might be for doing this in healthcare. And if you could move to the next slide, I can talk you through that in a bit more detail. So in 2014, we published a paper in BMJ Quality and Safety suggesting that positive deviance might be a useful approach. And if you could just click forward, please, that would be really great. Sorry, back one slide. It does have a number of embedded animations in it, but they're obviously not working within the current setup. So the first piece of work we did.
We'll edit that back in later.
No worries. Where we talked about positive deviance, we identified that the premise of it is that solutions to common problems actually exist within clinical communities. And rather than externally imposing rules, regulations, guidance on clinical teams to encourage them to act more reliably or to do things differently, that we could actually learn from those teams within the NHS and other clinical communities that were already doing things exceptionally well, perhaps achieving very high standards in safety. And we could learn from them, and we could then disseminate that wisdom to other teams who were doing a similar job or function. So that was the premise of positive deviance, and it really fit well with our kind of approach to patient safety, or certainly the approach we wanted to take. So the next thing we did was we started to explore methods that had been used in healthcare for doing positive deviance, and Ruth actually embarked on a PhD, and the first stage of that PhD was to do a systematic review of methods that were used in an NHS setting or any healthcare setting that would help us to understand how could we go about doing this. And what we learned from that was that there is a real need for feasible and efficient methods which allow you to maintain rigour and quality, but at the same time work effectively from the bottom up with staff and patients and involve those groups in identifying positive deviance and then helping to spread it. And what we found was that within the current literature, that balance between bottom up and rigour had yet to be struck. Either we found identified papers that journal articles that where researchers had spent huge amounts of time and effort and resource to identify positive deviance, and perhaps hadn't involved clinical communities all that much or all that well, or we found fairly weak methodological designs which weren't very convincing in terms of, well, had they truly identified the positive deviance here? Had they done enough to identify what was happening to allow that deviance to be, or that exceptional practice to be achieved? So knowing that the methods weren't quite there, we set out with the Clark funding to try and test and develop our own methods for doing positive deviance in a healthcare setting. If you could move on slides, please. So very simply put, positive deviance is about identifying the odd ones out, the people who are doing exceptionally well, but rather than exceptionally poorly, as we commonly do. Try to understand what it is those individuals, teams, organisations are doing to achieve that excellence, and then work to disseminate that more broadly. So really, from our point of view, it's a fairly straightforward approach. Very bottom up and not top down. And I'll hand over to Ruth at that point. If you could move the slides on, please.
So for the work that we've been doing to try and implement the positive deviance approach within healthcare organisations, we've been guided by a framework devised by Elizabeth Bradley and colleagues over in America. And this is a framework that's been proposed specifically for implementing the positive deviance approach within healthcare organisations. And it's basically kind of proposed on 4 different steps. So the first step is around using routinely collected data, reliable data, to identify teams, organisations or individuals that seem to be performing exceptionally well, so your positive deviance. The second step is about trying to qualitatively try and understand what it is that they're doing to succeed, so you can generate hypotheses about what their essentially positively deviant strategies may be. The third step is then around trying to quantitatively test those hypotheses on those strategies within a much more wider, larger representative sample. And then the final stage is around disseminating those strategies that are effective to others, similar communities, similar teams and organisations within healthcare organisations. So that framework is what we've been using as a team throughout the Clark to basically try and test the methods and develop the methods that can be used to implement that. So if you move on to the next slide, I'm going to talk you through 4 quite different applications in ways that we've tried to apply that 4-stage Bradley model to healthcare applications of the approach. So firstly, the first one was part of my PhD, and we, as I say, we were trying to use pragmatic methods within this study to implement the positive deviance approach so that it could be applied by frontline improvers. So we used routinely collected and publicly available NHS safety thermometer data to identify elderly medical wards within Yorkshire and Humber that seemed to deliver exceptionally safe care to their patients, and compared them with a comparison group of wards that delivered slightly above average safety performances. And using focus groups and brief field notes, we identified 14 different factors that staff perceived facilitated exceptionally safe care within their wards. So there are essentially 14 different positively deviant strategies. And you'll notice at the third step, I'm sure we'll come on to discuss this in a bit more detail. We didn't, based on the findings that we had, we weren't really able to conduct that third step, and so we've moved to the 4th step at the moment, where a team based in Sheffield are using a co-design method to see whether they can successfully, through co-design, disseminate strategies to other similar wards, elderly medical wards within the region. The second big project that we've done as part of the Clark was again trying to test the methods for the approach. So we didn't really go in with a specific patient population or specific set of measure or outcome that we had in mind. We were open to how we would apply the approach, and through a rigorous consensus and criteria generating approach, we decided to use patient reported outcome measures and 30-day emergency readmission data to identify providers that delivered exceptional elective hip and knee surgical surgery to their patients, the providers of that surgery. For this study, we again went into one positively deviant and a slightly above average comparator, but for this study we used much more in-depth methods, so an in-depth ethnography of each site. And we're currently at the stage at the moment of doing stage 3. So we've generated a survey, sent that out nationally to hip and knee, elective hip and knee surgery providers, and are just collating that data and analysing it against our original outcome measures. If you go to the next slide, please. So then the next study is very different again to these previous 2. So in the other 2, we've set out to follow the 4 steps, whereas this one really we've never really intended to go from stage 1 to stage 4 with this. So we're doing stage 1 and 2 as part of this project, identifying and understanding how teams succeed, and that we're using that information to feed into the development of a much wider intervention that will include other evidence and other data generation that we've conducted. So for this study, we've been identifying general practices and hospital specialties that deliver exceptionally low or reducing readmission rates for older people, and we're trying to understand what those teams will do to successfully support patients as they move from hospital to home, and that information will go into generate an intervention to support that which we're developing at the moment. And the final one, again, is very different. Whereas the other applications we've
I think we might have lost Ruth for a second there. Ruth, can you hear us? There might be a slight technical issue. Just check, Lars, you're still with us?
Yes.
Excellent. We're going to hope that Ruth is able to rejoin in just 1 second. There might just be a slight network issue in Bradford. So what we'll do, if it's okay, first of all, Danny, should we just have a mind about how people can get involved?
Yeah, absolutely. There's 3 ways that you can get involved. The first is to email us at hello@kaleidoscope.healthcare. The second is via our Twitter handle @kscopehealth. And finally, there should be an ask question box in your GoToMeeting bar on the right-hand side of your screen, and you can send questions there.
Okay, and we'll come to questions after both presentations, but please do send us through all thoughts, reflections, comments as we go through. Can I just check, Ruth, have we got you back?
Yes.
Excellent, great. You just explained to us the general practice example. We lost you just for a moment.
All right, I was just at the very end, I just said we've, in terms of the project that was around general practice and hospital specialties as part of a wider intervention, is that where you lost us?
Yes, I think you're just...
Okay, we're basically trying to identify general practice and hospital specialties with exceptionally low or reducing readmission rates to try and understand how they deliver safe transitions for older people as they move from hospital to home. And we'll be using that data to help develop a much wider intervention, along with data that we'll have gathered from patients and carers and also the existing literature, to develop an intervention to improve safety and experience during that transition. And then the final example we were just sharing with you was around a much more individual-based application of the approach. So rather than focusing on teams and organisations, we've looked at National Health Service Journal Innovators Awards, identified nominees from that, and then tried to understand through interview with certain people nominated for that award how they try and innovate within the NHS to improve quality and safety. So I hope that gives a bit of a whistle-stop tour of what we've been doing.
So one of the things we haven't been able to do is talk about any of the findings because that was so brief, but we are very happy to talk through the findings at any point you want us to.
Lovely. That's Ruth Becker. Thank you very much. Excellent introduction. Lots of food for thought. Why on earth we don't talk more about positivity possibly is one. So let's go from a country which focuses on the negative to a country which we always hold up as the solution pretty much to any problem you could ever think of, Lars. So Lars, thank you very much for joining us from Copenhagen. And a lot of it might be worth saying that we first had a conversation sort of a couple of years ago about your work in positive deviance, which I have to say I had a bit of a soft spot for as 2 ex-civil servants connecting. It was a lovely conversation to have. But Lars, do you want to introduce yourself and talk about your approach in Denmark?
Thank you very much, and thank you very much for inviting me for this webinar. I've been looking very much forward to discussing with you, so please ask us really good questions in the end. So very briefly, my background is in the civil servants. I have been 15 years in the Ministry of Justice in Denmark, and basically I think my story is a little bit the same as you explained, Rebecca, because I found that so many things were negative. I found that we focused on errors instead of assets. We were also stuck because our usual approaches didn't work well when we wanted to solve complex and complicated problems. So 12 years ago, I got familiar with the positive deviance approach during my studies at Oxford, and I came away both inspired and puzzled. Inspired because I thought, oh, this might be, something we could use, but also puzzled and even frustrated, perhaps, because I knew I needed to reboot and forget almost everything that I have learned, and actually start being a non-expert and asking open-ended questions instead of being an expert. So that's how it all got started. We worked with it within the Ministry of Justice with prisons and prisoners and guards and social workers. We're quite successful. I won't be sharing that case today. And then 4 years ago, I decided that that I wanted to do more of this in other sectors, but also before people end up in prisons. So I work a lot with young people. I work a lot with different vulnerable groups in Scandinavia, but also within the UN system and international NGOs and so on. A little bit in the UK sometimes too. Anyway, so we have a similar definition. I think some of the words are a little bit different, but basically it's the same. So it's basically the fact when we talk about positive deviance, or which we call it in many settings positive champions or positive outliers, because sometimes deviance has a little bit negative sound. But it's basically the facts that in all communities there will be, we believe, and we have a hypothesis that there are individuals or groups who have unusual behaviors that make it possible to find better practices to solve their problems than their peers. And that's despite the fact that they have exactly the same resources or access to resources or constraints. So that's basically the whole idea. And next slide, please. So here you see the founding father, Jerry Sternin, who is doing what we call the flip. And the flip is basically that once we have, and we've spent a lot of time and effort together with the communities to define the problems, because very often what we see is that the communities see the problems in very different ways than, for example, management, or could be decision makers, policy makers, etc. But once we have defined the problems, we flip, and instead of looking at errors and what doesn't work, which we tend to do in Scandinavia too, I can assure you, Rick, then we flip and look for the positive outliers. And you can see on the right-hand side of the slide, you can see the normal distribution curve, where you see the red arrow pointing to what we would say usually the 5 to 10% positive outliers. And we dig into and explore, what do these outliers, what do these champions, what do these deviants do? How do they do it? With whom do they do it? When do they do it? And so on. Because if we are not able to ask all these all these questions, then we really can't learn from them. So next slide, please. So basically we have a process which is very similar. This process is the original one from the positive.org organization, but it's very, very much the same. We have what we call the 4 Ds. We define the problem with the community. So it's not us as consultants, experts, civil servants, doctors, whatever. It's them, it's those people who own the problem. And we help by asking good questions, open-ended questions. Secondly, we have the discover phase, where basically we try to understand what's going on in this community, in this organization, what is the usual behavior, the usual practices. Thirdly, we have a determine phase, where we find the deviant behaviors or the champions or whatever we call them. And that's where we ask all these who, what, when, how questions and like that to be able to learn from them. And finally, the 4th D, where we practice our way or act our way into a new way of thinking by designing peer-to-peer learning. So it's not a talking at or from the top and rolling out approach. It's really a peer-to-peer, community member to community member learning process, which is the 4th D. And then I would just like to ask the organizers, because Rebecca, you briefly said that I will be talking about the Vietnam example. That was not my plan, but I can do it in one.
That's fine. Sorry, I thought you may, but that's fine.
But I can do it in 1 minute if you like. Would you like that?
Your 60-second clock starts now, Lars.
Okay. So in 1990, where the Sternins went to Vietnam, there was a huge problem in villages with malnutrition of children. So 65% of the children were malnourished, and as you might be aware of, that creates low resistance to infection, weakening of the immune system, and actually 1 out of 5 was in danger of dying. So it was a really, really serious problem. They got a 6-month visa, the Sternins, and were asked to see if they could actually do something. And good people had been doing a lot of efforts, but without success. There had been many projects with manna from heaven, or food supplies and so on, but they went back to the problem stage after the projects were over. So what were the PD? So they went out, they weighted the children, they found out that there were positive deviants, children who weighted more than the others, and they asked, so what do these families actually do? So 3 small examples. If you imagine these are 2 balls of rice, this is a normal family and this is a deviant family. So the normal family, what they would do was, and that was the common practice, was they fed their children in the morning and in the evening, so 2 times a day. So the deviant family, some of them, they practiced in another way. So they fed them once, twice, 3 times, 4 times, sometimes even 5 times a day. Exactly the same amount of resources, which was not a lot of rice, but we know, of course, that it's good to have smaller meals during the day. So that was one way. Another way was that they actually went down to the rice fields and found crabs and shrimps, which was not considered food for human beings, and especially not for kids. But they blended that into the food, and in that way they got more protein and so on. There were also other examples, but I will stop here. And in 6 months, actually 40% out of the children rehabilitated, 20% went from severe to moderate malnutrition, and in 2 years, over 90% of the children were rehabilitated. So that was the first example of PD. That has been applied in many parts of the world, over 100 projects, many within nutrition, but also in many other areas. And I think we have more than 60 countries now or something, including obviously the UK and here in Scandinavia and so on. But I would like to talk about 2 small stories, and please take the next slide. So, because we talk about healthcare today, I think it would, of course, nutrition has something to do with healthcare, but I would like to maybe mention I guess it's the first healthcare example that we have within the PD world. So MRSA, multi-resistant bacteria in hospitals, is a huge problem in many countries. In the US, I think almost 400 people die every day. And we know that it's all about hygiene. We know it's about washing your hands and cleaning the tools and all that after surgery and so on. But people don't comply. Doctors don't comply. Most nurses don't comply, and so on. So they basically had a similar situation, like you explained, Rebecca, with a lot of good people. Can you still hear me?
Yes.
Yeah. Okay. With a lot of good people, competent people who have tried a lot of things, but without success. So they decided in one hospital in Pittsburgh to try this out, try this approach, though it was very, very different from what doctors and surgeons usually do. As you might imagine, and maybe it's different in the UK, but at least in the US and also here in Scandinavia and other countries, surgeons are very important people because they save lives. So they are very, very important. At least sometimes we joke a little bit and say we have God and then we have the surgeons. I don't know if that's true in the UK. But anyway, so many surgeons, they are very, very busy too because they run from one surgery to another. Obviously, they need to make good use of their time. So we had the normal behavior, and there on the slide you see a surgeon with a gown. The normal behavior would simply be to take your gown off very quickly and throw it, in the corner, and then somebody, a cleaning person, would come, pick it up, and put it into the garbage can. Here we see Jasper Palmer, who was a positive deviant. So basically what he did was to take off his gown, fold it very carefully, slowly, and he even took the gloves, the plastic gloves off, and put it around the gown and then put it into the garbage can. And it's a very simple, banal example, but of course you can see that in Jasper's practice was a champion practice. It was a practice who actually helped to to not spread bacteria and so on. Priests in hospitals, here we have the Bible. They're usually also very important people, maybe not as important as surgeons, but still. They go from patient to patient, and especially in palliative care and so on, to talk with people and so on. And what they do is simply that they ask the patients to put the hand on the Bible, and then they bless them and so on. And you can see when they walk from patient to patient, the bacteria are spreading. So we found priests who had a deviant behavior. So basically, they had put a small piece of plastic film around the Bible, and then they had some hand cleaning gel or alcohol that they cleaned the Bible in between the different visits to the patients. And again, you can see that that is a champion behavior. On the slide, you see what happened to the MRSA rates and the use of gown and glove, and this type of behaviors and practices, PD processes has now been upscaled to over 100 hospitals in the US. I think that's all for now.
Lars, thank you very much indeed. And just to say, Lars, we're not going to play that video just for bandwidth issues, but we will send around a link to the YouTube of the chat with the gloves. It's well worth a watch if you haven't already seen it. Lars, thank you very much. Danny, questions? How can people join in?
So there's 3 ways that you can join in. So you can send an email to us at hello@kaleidoscope.healthcare. You can use Twitter via our handle @kscopehealth, or you can use the ask feature. I've forgotten. I've said it twice already and I've forgotten. There's an ask feature in the bar on the side of the screen, so you can put your questions through to there. Can I ask the first question?
I love it. I wondered if you wanted to give any reactions to Lars' portrayal of surgeons, being a surgeon yourself. What people want to come back to.
I was thinking about that. Sorry, Danny.
I think surgeons usually say God and then surgeons sometimes, rather than the other way around, like you said, Lars. But I think we should probably just leave it at that and move on. So one of the things that struck me then is that you both had slightly different definitions and slightly different processes in the way that you use positive deviance. And I was wondering, number one, does it matter? And number two, does it just represent really an evolution of the process? So I think, Ruth, you mentioned Elizabeth Bradley's methodology. Would you mind giving your opinion first on that?
Yeah, of course. I don't know that it's necessarily evolutions of the process, because from my perspective, particularly within healthcare, I don't know what Lars would say. I think the processes in both settings are probably still evolving, and there's a lot that we don't know and methods that we don't quite understand how best to apply and things like that. So I think they're both probably evolving. I think they're probably 2 different processes for two different settings potentially, just in that healthcare is obviously directed a lot more by numbers, statistics, being able to measure and prove that something does have a beneficial outcome or a negative outcome, as there's been the kind of traditional approach. And so the Bradley model is far more weighted towards that kind of mindset than I think Lars's approach, which has kind of been the traditional approach within public health and more social settings. I don't know if Lars...
Yeah, I think it makes a lot of sense. In our preparation for this webinar, we talked briefly about it too, and I'm not a healthcare expert, but I think some sectors have a very, very scientific approach to change and to leadership and so on. That's probably, I would imagine, the case with the work you've been doing, Rebecca and Ruth. And we have also seen it in the US, as I mentioned before. It really took some courage and guts to actually get started with this, because people were like, but where are the numbers? Where are your hypotheses? Where are the data? In some other sectors, it's very different. And as for example, I work a lot within what I would call the social sector, with Roma communities in Europe, immigrants, vulnerable families, youth, etc. And people tend to have a more, I would say, human-centered, or they are very warm-hearted people, and they want to know how people are feeling and what they're doing instead of talking about hard data. So actually, sometimes we find it really difficult in the social sector to have the hard data combined with the softer qualitative data. And I think both qualitative and hard data are similarly important. So we can't, you can't, I usually say, you can't talk without numbers, and you can't number things without talk. So you need both, but it's, I think the culture perhaps in different sectors might also set the, well, might define how we go along to get started. So I think, and it's still evolving, definitely. So it's not, you know, it's a very dynamic approach, I think, and I think it's being applied in different ways, in different sectors, in different countries, all over the world. So yeah.
Can I jump in the question?
Of course.
Which is, and Ruth, Becca, Lars, thank you once again for, I think, really articulate presentations. And so there might be people listening in who say, I've heard this before. It's simply sharing good practice, isn't it? And we do talk a lot about best practice and spread in the NHS in particular. So we're really interested in your views about how is taking a positive deviance approach distinct to how we might normally think about best practice, or simply just taking a template from one area and give it to another. Rebecca, Ruth, do you want to start, and then Lars?
Yeah, so shall I kick off, Ruth, and then you can add anything if I miss. But I think my view is that there are two things that make positive deviance different from just identifying best practice. First is the point that Lars made, that when you're doing positive deviance work, it's really important to make sure that you're identifying communities with the same resources and constraints as other communities. And I think one of the things that we sometimes do in our best practice work is that we can be tempted to go and identify best practice where perhaps they've got a bit of extra funding, or they're a centre of excellence already, which means they only deal with a particular patient group, or they've got the most fantastic group of staff there because they're the best centre in the world for that. And then other people from different communities then look at that and say, well, we could never achieve that because they're just different from us. They have those resources or those resources. So I think one of the stipulations of a positive deviance approach is that you go to a site, to an organisation, to an individual who's pretty much the same as anybody else, who's under the same constraints and resources. And actually, when we do our statistical analysis to identify sites, we take those factors into account. So in our statistical analysis, we would make sure that the sites were very similar to each other before we started to identify those that were managing to do something in a different way. And then that's the second point. Best practice tends to assume that people are perhaps following the guidelines or doing the procedures correctly, or doing something that they've been instructed to do. But with positive deviance, you might actually find people doing something that's slightly at odds with what the recommended practices or the guidelines are, but that allows them to achieve something new, unique. So for me, they're the two things that perhaps make it different from just identifying best practice.
I'd say in addition to that, I think one of the key things is that it should be, and I think sometimes the healthcare applications, particularly that are research led, lack this to a degree, and probably Lars's work would be far more do this far better. Positive deviance compared to identifying best practice and asking people to implement that, it should really be very community driven. It should be the problems that are important to staff on the front line, and they should be a part of generating that. And sometimes I think we lose that within healthcare applications of positive deviance, and we need to try and work better at developing the methods to enable that a bit more effectively. But if we can manage to do that better, I think that would be something that really would stand the two different approaches apart. And potentially give the edge to positive deviance, because hopefully at that point then the kind of adoption and dissemination of those behaviours should be a lot easier, because people are engaged, want to do those things rather than being told from above that they need to do it.
Thanks, Becca. Thanks so much. Lars, do you want to pick up the thread?
So there is nothing wrong with best practices. The problem is that they tend not to work when we have really complex problems. And I very often meet people who say, "Oh, we are already doing this, and it's just another word for best practice and so on." But the problem is that we haven't solved the problems. So, as I said before, really good, competent people have tried everything, but without sustainable success. So, and maybe a short story in the original Vietnam example, what happened once they identified the PD behaviors among the families. It was very tempting for Jerry Sternin and his wife, Monique, and the team to say, "Oh, now we know about the behavior, so we will tell people what to do." So that would be a traditional best practice way of doing it. So then there was this wise elderly lady, which was a Vietnamese lady who was in the team, and she said, "Well, let's think a little bit about this." And she said, there is an old proverb saying, "One seeing is worth 100 tellings, and one doing is worth 1,000 seeings." So what does that mean? That means that when you do something and when you try something yourself with peers, it's much easier than being told from somebody else, which is outside of your community. We also say sometimes that it needs to be you need to be part of the same DNA. So it's people just like me, just like you, that actually act in new ways. And that's why we have a very important principle saying that we act our way into a new way of thinking.
Last week, Becca, I don't know about anyone else joining, but it's I'm running through a mental checklist of how we change in the NHS. You go, okay, same resources and constraints. No, we don't really do that. Just telling people what to do. Yeah, we're good at doing that. But I think that's just on that same constraints point. It immediately makes me think about how we normally approach pilots, for example, where we deliberately give areas different resources and different constraints, and then expect other people to do the same, and then we're sort of slightly surprised when they don't. So I think that's a really good observation. Danny, questions?
Yeah, so one of the questions that's come through is really about the dissemination, and Lars, you touched on it there a little bit. But you know, one of the questions that we have is, you talked about peer-to-peer sharing and knowledge sharing and learning, and you know, when you've got somebody who's made a change and done it and shown success, are they better as someone to disseminate, or is it an early adopter? So you can find someone who will give it a go and is willing to take that risk, and then are they better for dissemination? Have you got any experience with that in your examples from outside healthcare?
So you said within healthcare or outside healthcare?
Outside healthcare.
Outside.
Or within, wherever.
Yeah, good. So I think the dissemination part is a really important, or the upscaling part is a really important thing to think about carefully, but also to understand. And as I said, when you act your way into a new way of thinking and use peer-to-peer learning, it's very different from classical approaches. But I would say that what is really important and sometimes really difficult, in Scandinavia, we have invented I think you call it the poppy syndrome or something, poppy drum syndrome, which is basically, I can explain it. It's basically that people do not stand up and say they're excellent. That's not part of our culture. So you would hide, or maybe, not tell anyone or something. So it's a really important job for the facilitator or even the manager sometimes to help people unfold their stories. So it's not about me, it's not about you, but it's about the behavior. So when we are able to do that, personal stories become more impersonal in a way, but still very human. But then you are able to talk about the behavior, and then it's not so difficult. So that's a really important thing. I think it's also important to think about what type of groups you work with. So, for example, right now we work with Roma kids in Macedonia and in Romania. They are very active. They can't concentrate for long hours. So we use very physical tools, practical tools like dramatic theater to engage them in the peer-to-peer learning process. Whereas I could imagine sometimes with other groups, you need to think about more kind of adult and not so fun, perhaps, tools. So I'm thinking, and to answer your question, Danny, I think early adapters, yes, but the more normal, or within the, I would say the 80%, the average group, the better. And I don't think you can educate and train everyone. I think that's not possible. So you will always find, I don't know, 5, 10, 30% who will not be able to learn. But that's, well, having, you know, perhaps 60 or 70% who actually adapt to the deviant behavior is something, you know, and that can actually help to solve a lot of problems. But you can't get 100% success rate. I don't think that's possible. Well, maybe in some areas, but I haven't seen them.
Where's your ambition, Lars?
and Rebecca and Ruth, does what Lars is saying resonate with you, the experience in health, or is it completely different?
Hello?
Hello?
Oh.
Can you still hear us?
Oh,
Yes. Yeah. Did you catch my question?
Yeah. No, could you repeat that, please? Sorry.
I mean, I'm just saying, does what Lars say really resonate with you in healthcare, or is the experience that you've had really quite different?
I think what's interesting is that quite a lot of the work that we've done has looked at fairly broad outcomes. So rather than focusing on a specific thing like hand hygiene or nutrition problems, we've actually been looking at kind of patient safety in the round. And what's been really interesting is that actually some of the dissemination that we need to do is not to other similar teams, but it's upwards to policymakers and organisational leaders, because some of the findings we've had are around what really makes a team function effectively to produce patient safety. So things like the top findings in Ruth's study were around staff having the opportunity to get to know one another. Being a multidisciplinary team and really putting in place things like meeting rooms and meetings and facilities to allow that to happen. This was on older people's medical wards, integrating the allied health professionals in those ward teams, feeling safe to ask questions and to speak up. So really the softer side of things have been some of our findings. Rather than you should do this behaviour or that behaviour, it's been more about how do you create a team who are just better able to produce outcomes in lots of different areas. Yeah. So we're not talking about just reducing falls or just reducing pressure ulcers. We're talking about how do you facilitate a safe team. And I think some of those findings really need to be fed up to policymakers, because if staff don't have the time to get to know each other, if handovers just aren't possible anymore, or safety huddles can't happen because they just don't have the time, if they're not encouraged to feel safe and not be bullied at work, then that teamwork that makes exceptional practice really starts to break down. Yeah. So I think some of the dissemination does need to happen across at this level, but some of it needs to head upwards.
Yeah. Can I make a comment, please? So I think that really resonates with our experience too. I sometimes say that the language you use at a community level, that's a very different one sometimes from the policy level. So we need to kind of find out how we can connect the levels. We had that discussion before, Richard, also a couple of years ago. And sometimes it's really, really banal things. I sometimes say that we are looking for the genius in the banalities when we work with PD. And very specifically in one of the projects we do right now with the UN system, we have identified champions, women survivors of violence, And what we did was actually to facilitate a process where we put those champions in the same rooms as the MPs. So, and that actually helped to process a new legislation to end violence against women and so on. So it's also, so I very much agree with what Rebecca just said.
Lars, and if I jump in, Danny, that's
yeah.
for 1 second, that Rebecca made a lovely point earlier about PD being different because you find out odd stuff. You find out things which you might not necessarily have been expecting. And I know you very briefly mentioned sort of the prison work, which sort of helps you get into this. But would you like to say a bit more about that and sort of what you found to be what you found to be some of those deviant behaviours which did make such a difference?
Well, 12 years ago, I was appointed to be head of strategy and innovation and in the ministry, and we had big challenges because we were criticized from the politicians, from the unions, from the prison governors, etc. There was high numbers of staff absenteeism, and there were violent behaviors in the prisons and so on. And we have tried, as in all other areas, a lot of, I think, competent things, but it didn't really work well. So I got familiar with the PD approach. And then we started working. We basically, that's very important too in the PD process, that it's voluntary. So we invited 10 institutions, 10 facilities to join a very first meeting. And I think 7 or 8 decided to come with their governors and a representative from the guards union and 1 staff member. And then we basically said, so we have some challenges here in our system, and we would like you to help us solve them. We don't have the answers. We have tried a lot of things. Would you like to join this process or not? And I think 5 institutions decided to join. And one of the things that we found that was really interesting, we found many PD behaviors, and within, it took actually quite some time. I think from 2008 to 12, we worked with this in various designs, depending on needs and so on. But one thing we found was keys are obviously a very important artifact tool in a prison. It's the key. I don't have a pair of keys here, but keys are the key to freedom, but it's also the key to imprisonment. And we found that most of the times in the maximum security prisons where people are locked up most of the time, they need to press a bell, and then there will be a bell, or they need to press a button, and then a bell will be ringing in the guard room. The guards will usually be quite busy doing something, casework, talking with each other and so on. So it might take, I don't know, 5 or 7 minutes before they actually get up and go to the cell and opens the door. And it's not that they're rude or anything, but it's just it's a distraction. It's they were in the middle of something and so on. And then we found these deviant guards who did it in a totally different way. So they thought, when they heard the bell, they thought, oh, he can't get out. I better get up now immediately because it might be something important. I will go along the hallway. I will make a little bit of noise with the keys so he can actually hear that I'm coming. I would actually stop in front of the door. I will take a deep breath because I don't know what's coming up right now, to get sort of ready for what's happening. And then I will knock on the door. I will wait a little. Maybe he doesn't say, the inmate doesn't say come in, and then I will put the key in the keyhole and I will turn slowly and open the door and say, okay, what's up? When we talk with the inmates about this difference in behavior, it's that it makes a whole lot of a difference. It's a very banal thing. It's a very simple thing to open a door, but the deviant guard or the champion guard, I can actually talk with him. I can actually, well, she's human. She understands that this is my private space. I live here. I can talk with her about rehabilitation issues and so on. So within a couple of years, staff absenteeism obviously dropped, meaning of work increased, numbers of threats and violence decreased, both among inmates and assaults on staff decreased, and so on. So that was just one behavior, but there are many others, but I don't think we have time for that today, perhaps.
It'd be lovely to go on, but I think that's such a lovely example, because if you take such a problem as, okay, absentee levels, and you think that the solution or part of the problem is keys, I think it's both counterintuitive, but also sort of remarkably sort of right for the nature of that. Lars, thank you very much. We're fast coming up on 5 o'clock. We'll finish at 5. I just want to check, Ruth, Rebecca, we can't see you, but can you still hear us?
We can vaguely hear you to a degree, but we've had to turn our video off because it means we definitely can't hear you if we have the video on, I'm afraid.
That's okay. That's prioritizing effort. Well, I think just okay. So with a couple of minutes left, Dan, it'd be great to get your reflections on our discussion. But then, Lars, I just wondered if you wanted to give just 30 seconds or a minute or so, just on your advice to others if they're interested in taking a PD approach, where to start. But Danny, first, your take on our discussion today.
Well, you started on the last question that came through there about how to get going with the methodology, but for me, it's about that flip that Lars showed. So taking the problem, identifying what the problem is, and then flipping that normal curve to find those positive deviants.
Lovely, that different approach. So Lars, it'd be great to hear sort of any advice you give to people considering this approach. And crossing fingers, Ruth, Becca, if we've still got you, your advice to others as well. But Lars first.
So I would say, don't be afraid. Get started and when you fail, which you will do, then learn from it. It's not that difficult. And then secondly, I would advise you to invite people like Ruth and Rebecca, perhaps people from Kaleidoscope, to join the process, because having an outsider's view, a stranger coming to town, asking stupid questions is really, really a good thing.
We're experts at that here. Thank you very much, Lars. And Ruth, Becca, your advice to people considering using a positive deviance approach.
Yeah, so I would say in the current climate of healthcare, anything that engages staff and increases morale is a fantastic pursuit, and this certainly does. So that would be my advice. Look for the positive, and I think you will start to engage staff, even if at first they don't recognise it in themselves.
Yeah, I'd agree with that. The staff that we've done the approach with, who we've involved within the research, have really liked being a part of those conversations. It's a conversation that they're not usually used to having, and they've really felt just instinctively that they've benefited and learned a lot from just having that discussion and being a part of that. So yeah, definitely echo what Rebecca said there around trying to focus on the positive.
Rebecca, Ruth, Lars, thank you very much. Danny, we'll come to you in terms of what's happening after today in just 1 second. But to see one quick reflection from myself on a discussion. I think the key point for me, Rebecca, I think the point that you made, that this starts with a presumption that the solutions already exist within a community. It doesn't require some expensive management consultants perhaps to come in from outside, or a regulator to say this is what you don't know, but actually how you unlock that talent within your community, within your staff group. I just love the positivity of that as a starting point, and certainly it really echoes with a lot of the work we are involved in here at Kaleidoscope. Danny, what's happening after today?
So the first event that we're going to be hosting is on Friday morning. I mentioned already, nuts and bolts of change. So that's going to have a great panel in the morning talking about how change starts in their context. We've got Paul Godin of Care Rooms, formerly of the New York Bagel Company, Will Warburton from the Health Foundation, Ruth Miller, a previous AbbVie prize winner, and also George Delisle of the Improved Care Now Network. And the main session will be focusing on micro actions as well. But if you'd like to be involved in the AbbVie event series, then you can tweet us at Kaleidoscope Health or email us at hello@kaleidoscope.healthcare.
Lovely, Danny, thank you very much indeed. A huge thanks again to Lars, Ruth, and Rebecca. A fantastic hour. Just to say that we have been recording, and we'll be sending around the video shortly. But for now, thanks all very much indeed, and we hope to see you at a future webinar. Thanks very much.
Bye.
Goodbye.
Thank you.
Thank you.
Thank you.
Bye.
Bye.